We're here at the International Conference on AIDS here in Vancouver, BC. We're here with Lynne Mofensen, Senior HIV Technical Advisor at Elizabeth Glaser Pediatric AIDS Foundation, and Natella Rakhmanina, Director of Technical Leadership at EGPATH, and also Professor of Pediatrics at George Washington University, Washington, D.C. Both of you come from Washington, D.C. Both of you are with the Elizabeth Glaser Pediatric AIDS Foundation, or EGPATH as you fondly call it. We have asked you to be here today because there's a lot of information that needs to be discussed and brought to bear about children and how they fare and how the change happens over the years, because as changes happen for adults, they happen for the youth and the children too, at pediatrics as well. So who wants to begin to give the pieces that need to be
start.
Okay.
I think that the big news here was more adult-oriented. The START study showed that that treatment was effective and important in individuals with a higher CD4 count. The 052 follow-up showed a persistence of benefit of treatment in terms of prevention of transmission. And for me, this was kind of just a reminder that we already knew this in pediatrics. In 2008, we showed in the SHARE study that starting young infants as young as 6 weeks reduced mortality by 75%. And way back in 1994, we showed with 076 that we could prevent the risk of transmission, moving all the way now to option B+, where transmission can be reduced to under 1%. So the adult news is very good, but this is not news for children, I think.
Do you remember when many years ago when we had put on, especially in developing world, put women on treatment just when they were ready to bear children? I mean, imagine how far we've come.
Yeah, we've come a huge amount of ways, and one of the interesting pieces on the issues dealing with prevention of mother-to-child transmission in this particular meeting, it wasn't on what do you use, it was on how do we actually implement what we know works. And there were a number of papers showing transmission rates, early transmission rates of 0.3%. So the focus was really on how do we retain women after they come in, and a number of different approaches were discussed, using mothers as peer advisors, bringing their male partners in and disclosure, community-based strategies. Elizabeth Glaser Pediatric AIDS Foundation did a study called ACCLAIM that looked at community-based strategies. So really the focus for PMTCT was on how can we retain women in care, as opposed to is this something we should do.
And you bring to this clinical relevance because you're right in the middle of treating.
Yes.
And before we go into that, let's break down for our audience who may not be familiar with this. Pediatrics, how do you break down the ages and what we're talking here? Pediatric is...
Well, you know, the WHO with their new guidelines for the first time is going to have an adolescent determination. So what they're going to define as children is 0 to 10. They're going to call adolescents 10 to 19. And then over 19 adults. This is actually a big advance for the WHO to be able to acknowledge that adolescents are a separate population that needs special attention.
And that's quite relevant, and in fact you're totally right. I already have several of my patient families, and I do practice clinical medicine in HIV in Washington, D.C., reaching out to me for some comments. As Lynne, I believe strongly that the big adult news is not news for us. We've been advocating using the drugs as a prevention for many years, and so the conceptual approach is not new. The ability to deliver efficient treatment to children, in that we're behind. So to me, it's a very interesting paradigm where I believe in our thinking we're somewhat ahead of adult world, but in our ability to deliver effective treatment, to have appropriate drug formulations for children, to do what we are now advocating everyone to do, is to start treatment right after you made the diagnosis. We are still limited with children, and we don't have much of the really exciting progress to report from this conference. A couple of newer drugs that are now showing up in children. I know Lynne and I have discussed the findings of the study on new formulation of tenofovir in adolescents. We have moved further on this conference using the raltegravir, which is a novel integrase inhibitor in a very young population of children. But again, you know, just to remind everybody, what was used in the scenario of Mississippi baby was not a standard of care. And we still are both limited in what we can offer young infants. So hopefully, through meetings like this and down the line, and as Lynne pointed out, the big emphasis right now is not just that we need to do it. We finally all agreed we just need to do it. It's how to do it and how to do it the best. And hopefully as we move in how to do it, we are on pediatric side really hope that we will be able to catch up with adult progress and in my dreams to bypass the success of adult. I also believe what Lynne said is very relevant. I do think that now we are going to recommend treat all, but in reality, under option B+, we already started treating women independent of their disease parameters. We started treating them in pregnancy for lifelong. So I also think we have a bit more evidence about the challenges of retention in the populations that do not require treatment based on their disease parameters. So I hope this can be nicely fused with a new rollout of the guidelines where we will offer treatment to everybody. And I hope there will be some very interesting junctions between retention of men on treatment and women postpartum. So
Or the whole family
model of treatment. That's really crucial because it's a big challenge. And equally, I'm very thrilled with the focus on adolescents. I can't say that this conference had a lot of highlights in terms of new data, but the determination and focus on adolescents and recognition that this is a population we have specific challenges with is a huge step forward. And I agree with Lynne. This definition of age existed before, 10 to 19 years old, but it never was put forward as a vulnerable group of people. When we said children and then we said adults. Now we are saying children, adolescents, and adults. And it's truly a big advancement.
And we had a plenary session devoted to adolescents, which was very nice. I mean, now that we've got really good treatments for children, they're surviving into adolescence.
Yes.
And we have a whole new set of problems in terms of complications of HIV, in terms of treatment complications from HIV, and a really nice problem is transitioning these youth from pediatric to adult
dosing
care.
And so forth.
No, just getting these youth, they're now 20, 25, you know, getting them from pediatric to adult care without losing them. And that's actually been a major issue, is that as the adolescents move from pediatrics to adult care, sometimes they'll drop out of care or stop taking their drugs. And Natella is actually has a whole program to deal with transition. So I think the attention that was given to this is very good because it's beginning to say, here's where the problems are, and that's the first way to start figuring out solutions to the problems.
Do you all, from the organizational perspective, do you represent the youth and the pediatric and the adolescents with the industry as they develop drugs? Do you engage with them in consultation ways in some form or another?
In multiple forms, absolutely. In the drug development process, absolutely. And very eager to collaborate with them. In fact, one of the studies on tenofovir, I was presenting the data from my clinical center in the US, but we're equally very supportive of doing the clinical trials and make sure these drugs are quickly approved and become available.
But that you have the formulations that are going to be acceptable to the age level and so forth.
Correct. And when the people think acceptable for young infants, all formulations need to be acceptable to all populations. Adolescents will not want to take a very large pill or multiple pills. We also have to think about their acceptability equally as well.
The pill and so forth.
Yes, we also advocate for them on advocacy levels, on the level of supporting adherence, which we find one of the major challenges of treatment success. And as Lynne pointed out, transition is a major problem. We don't have good data what happens with those who grew up with HIV after they've transitioned. We have few studies, and these studies indeed highlight this is a area of problem, but we don't have really good universal data. So a couple of really wonderful initiatives here. We're continuing to develop. One is by IAS, the CIPHER initiative, creating large cohorts to observe on a very large number of children and adolescents what happens with them, and the focus on adolescents is quite high. Transition, we discussed issues like disclosure. When do you tell and how do you tell the young person who is infected that he's infected with HIV, or at the childhood, how do you teach him to or her to handle this information
With
in their
others,
adult
in their-
life, right?
And with others. Yeah.
All of these issues have become a topic of the conference, which is really fantastic news.
Now, when you look at, say, the evolution, when a person comes to you who's bearing a child, so that becomes the trigger to say, okay, now we have to prepare for your birth, and also for that child, and then the husband needs to be involved because they don't want to feel like, okay, you're getting treatment because you're the mother and the child, but I'm out here in left field. I don't, it's kind of almost like they have to receive as a family unit.
Correct.
And I know that there was a number of studies, not too recent, not too far off, that happened that the men were not invited to the decision-making moment where the woman engaged to become involved with the trial. She took the information home, and they said, "Don't do it."
Yeah.
And they'd end up. So you really have to engage the whole family.
There was a nice presentation about this, about extending, and this is in Africa, extending an invitation to the partner and having a peer person be able to go to the community and actually approach that man and help to bring him in with his wife so that they can get jointly counseled and tested. And that was found to improve the mothers taking the drugs that they need to take. So
Right. You don't want to have them be on the outside. They have to be invited to participate in a very real family way.
And in relation to that, Lynn, there was also a very strong focus in several presentations on those women who test negative, but if we do not know the status of the husbands or partners, we are at risk because we are not going to give prophylaxis to this woman. We are not planning on it, but yet the woman can become infected during her pregnancy at a certain point. So were quite nice, I believe, several presentations, including poster and oral discussion about how can we reach out to the male partner of pregnant woman and make sure that we know his status.
yes,
Right.
yeah.
So other pieces, because we definitely need to understand how to communicate to our viewers about what it is you're doing, and I don't want to miss anything because I think your work
one
is very
thing I'd
important.
like to bring up, which we talked about a little bit before we were taping, which is the case that got the biggest attention in pediatrics, which is this adolescent girl who appears to have controlled her virus off of medication. And I guess the one thing that I want to get across to the community is do not stop your kids on treatment, because this child is not cured. This child still has virus that they can make replicate. And my big concern is that all of the press around this will mislead parents.
It's a very novel situation. We don't know why. We're learning because it's just an odd situation.
Right.
That is very unique.
It's not that unique, in fact. We call these people elite controllers to a certain degree. That terminology has been known. And I actually want very much to reinforce what Lynn said. I recently saw in our practice a young woman who has a case of perinatal HIV infection, and she was seeing me with her second child. This is very similar scenario. I have not done any virology studies or studied her history quite great in detail to really compare her medically to the French case. However, she did report to me, and I had her laboratory results. Indeed, she had a viral load under 50 copies most of her life. And in fact, that woman chose to go on antiretroviral prophylaxis in pregnancy with her provider, which just emphasizes the point Lynn made. She still did not consider herself. There were periodically some small, what we call blips of viral load when her viral load raised. She didn't want to take absolutely any risk to transmit the virus to her baby. So despite having history of not being treated herself, during her pregnancy, she went on medications to really achieve the maximal prophylaxis for her baby.
Advantage,
And in
yeah.
fact, I have not had a chance to personally attend the oral presentation on the case from France, but that would have been one of my questions.
If in
to
fact
the
it is
group.
an elite controller or a virologic controller, however you describe it, we are now understanding, and Steve Deeks and a number of in his group and have done the work and said, you know, there's still immune
immune activation. There's
Yes.
still potentially late complications, and you know, again, my big concern is that people will hear this and say, well, I'm going to take my child off of medicine.
Very
because
good point. I'm glad that you're bringing that out, because it has to be, I mean, that's the purpose of this,
Yes.
to bring people back to the reality of what we do know in science.
Right.
Because at one time it was like, you know, people doesn't have to be on treatment if you didn't seem to, but now we know there's immune dysfunction, there's, you know, inflammation going on, and there is low-grade
And we've
activity.
got drugs that will be able to make people live until they're young adults, old adults.
Yeah.
But you have to take the drugs.
Yeah,
Yes.
the drugs that work are the ones that you take.
Take, exactly,
Yes.
yes.
Another relationship to the treatment is, in order for us to offer this array of drugs that Lynne refers, which we indeed we have such great array of choices for adults. We still, again, are behind in kids, but we are moving in the right direction. We need to know the people's status.
Yes.
And we need to be able to diagnose it. And we still feel that and not only we feel, we have data at this meeting, that only half of people worldwide approximately know their status. So there is still a lot of work to do. And relevant to what ECPAF is doing, we really try to make sure what we call close the testing cascade in the young infants born to the women with HIV, because we do everything nowadays to prophylax, but we know people, as we just talked, retention is an issue. So if the breastfeeding woman, for whatever reason, is unable to maintain a good adherence to her treatment, but she continues to breastfeed, the baby remains her already not newborn, her child, it remains at risk for HIV. So we currently test children at 4 to 6 weeks of age.
That's when the
After
virus
they are
will
born.
show
We
up.
test them at 9 months of age, and we test them with a final test at 18 months of age, or when the breastfeeding is stopped.
Stopped, right.
And we still feel that we do not do an excellent job in really making all the points. We talked about this at this meeting, and as a part of the consideration and truly an attempt to complete this testing, at ECPAF, we are very proud to become recipients of the UNITAID, a very large grant by UNITAID to move forward the point of care testing algorithm.
So there'd be more testing within that.
More testing within that.
Instead of 3 times, it may be 5 or something.
No,
like that.
we will stay with 3. We just
Okay.
want to make sure it gets done and people
Oh, I see.
actually
Okay,
get the
yeah,
results
I gotcha.
as a point of care testing. So a lot of developments are happening. Technology is just on the brink. I believe we can say that.
Yeah,
Lynne?
this is really important, because at least in developing countries, it can take 3 months from the time the test is done until the test result comes back and the child is started on treatment. And in very young children, the risk of dying from HIV is very high in those first few
Yeah, yeah.
months. So a point of care would allow you to test the child in the clinic, get a positive test, start treatment immediately.
I think, yeah, I saw that. I didn't see that presentation, but I saw that was listed. Yeah,
Yeah,
very
we will be
important.
working in 9 out of our 14
Quick
countries
turnaround,
to move this forward within the next 4 years, and really hope that we do transition, as Lynne said, from standard tests, not in all circumstances, and certain maybe algorithms, they still are workable, but we really want to avoid this delay between knowing, obtaining the blood from the young child and knowing his status. Because if we know it's positive, we
can
can
start
really make a
treatment.
difference.
How many countries is EGPATH working in?
14
14.
countries.
Amazing.
Yes,
We thank you very much for being here.
It's a pleasure.
Thank
It's a
you.
pleasure.
Thank you.
Thank you.
Thank you, Natella.
Thank you.